So this presentation will be much more centered about, you know, the calyx or the smile complications. Why do these complications matter nowadays? The issue of increasing adoption of these platforms, the variety of these new platforms bring a different set of complications. They are not complication free, as we thought in the beginning. We thought that bringing a smile, for example, or another calyx into refractive surgery will get rid us of these complications, but really we had a different set of complications. So these are technically demanding instruments, and the procedure itself requires a lot of blind maneuvers. Usually, the more you get, the more you do cases, the better the outcome and the avoidance of complications. So how to avoid complications? Usually, we start with the prevention. Selecting the best patient initially is one of the things which will prevent complications. So you have to do good refraction, select myopic patients rather than hyperopic patients in the beginning, avoiding the low myop, the high astigmatic cases, avoiding anxious and uncooperative patients. Facial morphology plays a role in smile surgery when because usually the cone of the instruments, these instruments, they have a big cone. So if the nose is large, if the eye is deep set, if there is small palpebral fissure, all these will cause problems for you. So what is the tip number 2? For me, you have to use an instrument to hold. I think the videos are not working. You have to use good instruments for the job. So whenever you have the right tool, you will get the right outcome. So one of the things I prefer now is to do a globe fixation. I started initially without a globe fixation. So usually the eye keeps roving and moving around when you do the procedures. But for the last 3 years, probably 2 or 3 years, I stopped doing this. I have to hold the eye with a forceps so we can stabilize the eye during the procedure. How to avoid retained lenticules? Many times, if you manage the minimum thickness of the lenticule, you can prevent these retained lenticules. So when you have a patient with a high myopia, let's say more than -3, -4, then getting the edge of the lenticule 10 to 15 micron is enough. But when you have low myop, usually you have to increase the thickness to up to 25 microns, so you get rid of these retained lenticules. Docking and centration depends on the machine, of course, but we talk much about, you know, VisioMax 500 and 800 here, because I think the base of the instrument is very wide in Iraq. So usually with the centration is more or less an auto centration. The patient is looking directly at a green light, and then once you touch the cornea, you can center it very well and you activate the suction. Corneal marking is needed when you have an astigmatism of more than 1 diopter usually. If you do corneal marking, you will get better results, because at the moment we don't have cyclotorsion activated into many of the machines. By the way, الفيديوهات مو شغالة.
Now, VisioMax as well as you can make it.
So with the newer machine, the VisioMax 800, you can use the joystick to move the reticule or move the cone into the desired position to avoid the cyclotorsion. But with the older one, the VisioMax 500, you have to move yourself the cone with the eye sucked into the cone. So it will be one piece like, so you move it according to the marking you have. What about the edge separation? Most of the time, to avoid, you know, posterior entry into the lenticule side, you have to use some maneuver, whatever maneuver you can.
We have swing, we have master, we have everything in the clinic.
It's okay. It's okay, no problem. We don't want to lose time. So with the edge separation, better to use the swing technique. The swinging technique, it means that you put the spatula or put the pointed edge circumferential parallel to the edge of the cap side cut, and then you move it up. You tent the cap or the anterior cornea, so the instrument will go above the lenticule very easily. In cases of lenticular extraction and separation, you have to use white strokes. Unfortunately, I'm sorry, the videos are not playing. So you have to use white strokes so you can dissect more or less, not in a jagged manner. The interface will be smoother interface, so the outcome will be better. And you have to keep, when you are dissecting the cap, the lenticule, sorry, you have to keep a small amount of the side cut of the lenticule attached, so it will act as a counter pressure so that you can dissect in an easier way. Cases of suction loss, prevention of cases of suction loss is something we are trying, but in many times, you know, it can be managed, but it cannot be prevented 100%. But one of the things, you have to avoid excessive fluid. If you put, for example, drops or Alkein or topical anesthetics just before docking, you'll get a lot of fluid around the eye and around the suction kit, so you increase the incidence of suction loss. So avoiding excessive fluid is important. You explain to the patient, you switch off the fixation light. I mean, this is not obvious here, but I mean, with the VisioMax 800, there's an option. Once you activate the suction, the light will be off, because most of the time there is reflections and the patient will start to try to find the green light. OBL and the black spots, they may cause problem with the dissection, and many times it's related to the presence of tear debris, oily tear film, the docking is poor, so you have to be also aware of these things. If the black spots are, you know, dense and central and large, it's better to abort the surgery and you stop doing it instead of, you know, dissecting through tissues which are uncut. You know, when the cornea is uncut and you dissect, you increase the risk of haze and poor outcome. Number 10, probably in perforations or incisional tears. These are not common, but if you have thin lenticules, okay, the side cuts are not thick enough, sometimes you go through the side cut prematurely and you are left with certain tags of the lenticule. So I minimize these with holding the eye and adjusting the side cut in a proportion to the amount of correction. Lenticular retention is something serious, so you have to be careful if you are not sure about the lenticules, if they are complete or not. You have to spread the lenticule over the eye and make sure it's complete. Otherwise, you have to go and dissect carefully with sharp instruments, as Dr. Hassanian said, so you can retrieve these fragments and you complete the puzzle you have, and you have a complete. One of the techniques which are easy technique, you can use an air bubble technique. You lift the cap itself, then you get an air bubble. You can visualize the side cut inside the pocket, so you make sure that your lenticule is completed. False plane dissection is one of the things which are really serious, because once you have a false plane and you continue dissecting, it will result definitely in deep scarring and poor visual outcome for the patient. So you have to be aware that these deep dissections may happen if you cannot identify and visualize the edges of the lenticule, the edges of the side cut very well. Use excessive force, thinking that there is some adhesion because of black spots, because of OBL. Then you sometimes you go into a deeper plane. So you have to stop dissection. Once you are not happy, you are not seeing things flowing as usual, you have to stop dissection. So at the end, prevention is the best cure. In terms of, you know, refractive surgery, things are not very forgiving. Calyx has its own set of complications, but most of them, they are preventable, and many of these are treatable either on the table or afterwards. But if recognized early, you can manage them very efficiently, and don't be hesitant to abort the surgery if in doubt. Patient will be angry probably about the surgery, but at the end of the day, next day, the patient can return to wear his glasses, and then you find another way to correct his vision. Thank you very much.